Motor neuron disease by Mitch Cameron. This presentation will discuss the elements of motor neuron disease, including the pathophysiology, the typical signs and symptoms, and some treatments and interventions which can help control these symptoms, the effects on movement control, benefits of exercise and guidelines for exercise prescription, and will be concluded with some key take-home points. Motor neuron disease, abbreviated as MND, is also called amyotrophic lateral sclerosis or Lou Gehrig's disease. MND is a progressive neurodegenerative disease and often begins with limb and muscle weakness in about 65% of patients, particularly in the hands and or feet. Motor neurons are nerve cells that control the voluntary muscles of the trunk and limbs and affect speech, swallowing, and breathing. Damage to these nerves causes muscle weakness and wasting, which leads to gradual paralysis, loss of speech, difficulty swallowing, and eventual death due to respiratory failure. Individuals suffering from MND need assistance with general daily tasks and have a lifespan of 1 to 5 years from the time of diagnosis. The only known MND diseases are hereditary. MND is a complex genetic disorder where multiple genetic and environmental factors combine to cause a disease, although many underlying mechanisms still remain unknown. Despite this, between 5 and 10% of MND cases are inherited. Gene mutations are reported as being the primary cause of MND. Co-segregation of MND with other neurodegenerative disorders in families suggests common genetic risks. However, genome-wide studies have shown that there is no single gene that accounts for most MND. Mutations in the gene encoding superoxide dismutase 1, which is abbreviated as SOD1, account for 20% of cases of genetic MND. The substitution of valine for alanine at position 4, abbreviated as A4V, is the most common SOD1 substitution. The remaining 80% are caused by other gene mutations. Distinct syndromes are caused by different SOD1 mutations, although these will differ in regards to SOD1 activity of erythrocytes, age at disease onset, survival, and clinical manifestations. Patients with the A4V mutation in SOD1, the corticospinal tracts are largely spared. Previous research has examined many environmental factors in the causes and mechanisms of MND. Documented risks include age, with most cases occurring between 55 and 65 years of age, and family history. Physical stress and exposure to pesticides are also possible contributors. Many neurologists, however, have studied the effects of environmental features, substances, and other exposures on the cause of MND, although with little supporting evidence to prove the environment as a large contributing factor. Once the disease has begun, several cellular processes occur. The exact molecular processes that cause the death of motor neurons in MND are unknown, however. Possible primary mechanisms include the toxic effects of mutant SOD1, including abnormal protein aggregation, the disorganization of intermediate filaments, and glutamate-mediated excitotoxicity and other abnormalities of intracellular calcium regulation in a process that may involve mitochondrial abnormalities and apoptosis. This presentation documents 7 main signs and symptoms of MND. The first one being cognitive decline and depression. Cognitive signs and symptoms in MND are due to frontotemporal impairment and include personality change, irritability, obsessions, poor insight, and impairments with language. Depression and anxiety can occur in MND and may impair the quality of life for patients and caregivers. Sialorrhea. Sialorrhea refers to an excess secretion of saliva. In MND, it is caused by dysphagia, which is a difficulty in swallowing, rather than increased saliva production, and affects 50% of patients. Sialorrhea can be socially embarrassing, and excess saliva can lead to aspiration pneumonia. The third symptom, spasticity. Spasticity is caused by loss of the normal inhibition from descending upper motor neurons. Some patients also develop jaw quivering or clenching due to upper motor neuron degeneration. Impaired sleep. Poor sleep in patients with MND has numerous causes, including respiratory insufficiency, difficulty repositioning in bed, pain, anxiety, and depression. Sleeplessness as a result leads to daytime fatigue, weakness, worsening respiratory function, and depression. The fifth symptom, fatigue. Fatigue is commonly experienced in MND and can be caused by overexpenditure of physical energy, stress or depression, poor sleep, and medication side effects. Constipation. Constipation occurs from immobility. inadequate fluid intake, and adverse effects from medication. Abdominal wall muscle weakness also contributes in the later stages of MND. The final symptom is pain. Immobility, emotional distress, muscle spasms, cramps, edema, or the illness itself may all cause pain. It is mostly important to identify the factors leading up to pain. Individuals diagnosed with MND may suffer from immobility, muscle spasms, cramps, and edema. Immobility can cause a wide range of complications. Physical complications of being immobile include muscle wasting, contractures, which are a permanent shortening of muscles or joints, muscle pain, and osteoporosis. Each complication contributes highly to movement restriction, therefore causing implications in regards to physical activity and exercise. Edema is an excess of fluid in the tissues and may result in an impaired function of tissues throughout the body. Swelling of the joints may cause pain and result in patients being uncomfortable during exercise. Edema can also potentially cause hypertension, which further complicates physical activity and exercise. Muscle spasms and cramps are involuntary muscle contractions and can be especially painful. Spasms can affect many different muscles in the body, causing complications during exercise. Spasms and cramps can occur abruptly, are painful, and are usually short-lived. Spasticity, which was mentioned in the above signs and symptoms, is also another major complication on movement control. The most effective way to treat MND is to address and treat each symptom separately. We'll start with the first one, cognitive decline and depression. Cognitive symptoms can be treated with behaviour modification. Depressive symptoms can be relieved using psychotherapy, and tricyclic antidepressants, known as TCAs, can assist with cognitive symptoms such as insomnia, drooling, and emotional lability. Selective serotonin reuptake inhibitors, known as SSRIs, and other antidepressants can be helpful when treating anxiety. Cialorrhea. Non-pharmacological interventions such as suction machines and inexsufflator or cough assist devices are effective in reducing saliva volume. Cialorrhea associated with mealtimes or a particular time of day can be treated with hyoscyamine due to its transient effect. Transdermal scopolamine, oral glycopyrrolate, or TCA medications are effective in providing a more continuous effect. Spasticity. Baclofen facilitates motor neuron inhibition and is therefore useful in reducing spasticity effects. Dantrolene sodium acts by blocking calcium release from the sarcoplasmic reticulum and reduces both rigidity and spasticity. Stretching exercises may also reduce muscle cramps and spasms. Impaired sleep. Physical interventions such as a power hospital bed and an alternating pressure mattress can enhance mobility and comfort. Nocturnal non-invasive positive pressure ventilation, known as NIPPV, can improve respiration and sleep quality. Antihistamine medications or chlorohydrate have sedatory effects, therefore promoting improved sleep. Fatigue. Energy conservation can be a simple treatment. Nocturnal respiratory insufficiency can be treated with NIPPV. Pyridostigmine can reduce symptoms of weakness by enhancing neuromuscular junction transmission. Constipation. Stool softeners such as docusate or senna leaf extract can be used as management. Increasing fluid intake and substituting medications with fewer anticholinergic effects is often helpful. Increasing dietary fibre in the form of prunes, fruit juices, applesauce or bran can also be effective. Pain. Medication can often be avoided using physical therapy, stretching and range of motion, known as RRM or ROM exercises, massage and limb elevation, as well as a support hose to reduce edema. Medical management includes benzodiazepines and opioids. Narcotics and anxiolytics are used towards the final illness stage in order to prevent suffering. Research has reported the benefits of both aerobic and resistance exercise in patients with neuromuscular diseases. Physical therapy aims to avoid joint contractures and stiffness that increase the disability of the patient. Physical therapy is primarily based on passive mobility and avoids exertion against resistance, which increases the denervation process. Regardless of the disease progression, the goal of any exercise prescription program is to ensure the patient can remain physically independent. During the early stages of MND, the patient is recommended to continue normal physical activity. Prescribed activities should include general active ROM and stretching of joints that are affected, resistance exercises of unaffected muscles with low to moderate weights, and aerobic activities at submaximal levels. As the disease progresses, patients are recommended to perform active assisted and passive ROM exercises in order to prevent contractures. Patients should not perform activities to the point of extreme fatigue, that is, where they cannot carry out daily activities. Patients should exercise for several brief periods throughout the day, so exercise time should total 30 to 45 minutes. As the disease progresses through to the later stages, the patient will eventually require a wheelchair and will become very dependent on physical movement, making exercise a nearly impossible task. Stretching and passive ROM exercise should be performed until further physiological health complications, that is, pain and serious respiratory problems, arise and therefore become the primary health priority. The presentation will conclude with several take-home summary points. Motor neuron disease is a neurodegenerative disease affecting nerve cells. There is currently no disease cure. Gene mutations have been shown to be the primary cause. There are many specific signs and symptoms which have effects on movement control. Many symptoms can be treated with both pharmacological and non-pharmacological interventions. And finally, physical activity has many health benefits with effective exercise prescription.